I will talk about our results that we achieved in Dresden and now in Zurich together with Theo Seiler. And I'm working at the University of Zurich, at the Technical University of Zurich, and I'm a scientific consultant of the wavelight laser technology. First I want to thank a few people, of course Theo Seiler, who's my boss, Guy Katsirian, Mike Kammerer, who's a research fellow in Dresden, Peter Myrtle, also from Dresden, Hans-Ebert Grinke, also from Dresden, Hans Batiste from Zurich, and Vladimir Samsishin from Moscow. Well, I want to short give you a background why we want to do wavefront guided LASIK. If patients came in for the follow-up in our clinic, most of them report, up to 30% of them report, that they have some kind of night driving problems. They do not complain, but if you ask them, they will tell you. Furthermore, we found in a clinical study that after normal standard LASIK, the wavefront aberrations are increased up to the factor of 5. So maybe there is a correlation between it, and that's the reason why we want to do wavefront guided LASIK. This graph would like to explain you a little bit more what's the aim of wavefront guided LASIK. If we compare the pupil size with visual acuity, we have mainly two limitations. We have some limitation of the retina. It's the retinal limit for visual acuity, which is in the order of 20/6, maybe 20/5. Actually, data are a little bit confusing in the literature. We have diffraction limits that are only valid for small pupil sizes in the order of 2 millimeters. We have reduced visual acuity in patients that are myopic or hyperopic. And we have a reduction of the visual acuity due to optical aberrations. So the eye is not able to see up to its retinal limits due to optical aberrations. And the goal now of wavefront guided LASIK is to correct these higher order optical aberrations to increase the visual acuity, especially in the large pupil sizes. So that means that we want to improve the visual acuity under night driving conditions, for example. So what's the aim of wavefront guided LASIK? We want to improve, or at least we do not want to deteriorate mesoptic visions, or for example low contrast visual acuity and the best corrected visual acuity. Within the prospective study we treated about 30 eyes, and I want to show you now the 3 months results that we actually have. Inclusion criteria were best corrected visual acuity better than 20/25, spherical equivalent less than 8 diopters. The age should be responsible for refractive surgery. No ocular pathology or refractive instability of the patient's eye. And the wavefront refraction versus the manifest refraction should not deviate more than half of a diopter. How do we correct these optical aberrations? We measure the wavefront, transfer this wavefront into an ablation profile, put it into the laser, and then do a standard normal LASIK treatment. One thing is that we do sphere, cylinder, and the higher order aberrations will be corrected within one step. So it's not necessary to do first a spherical or cylindrical treatment and then correct the optical aberrations. We did it in one step. We believe eye tracking is mandatory, and each measurement and the treatment was centered on the principal line of sight. The laser we used was a scanning spot laser having a 1 millimeter spot. The repetition rate was 200 Hertz. The eye tracking response time between image capturing and movement of the mirrors was about 8 milliseconds. The built-in profile was so-called bullet-like. This was a Gaussian beam profile where we cut off the wings that were not used for ablation, and the system was from Wavelight. How we do wavefront analysis, we use the churning aberrometer that was developed in Dresden. We calculated the wavefront aberrations up to the 6th order, which means about 27 sonical coefficients. The pupil size was in all measurements larger than the optical zone used for the treatment. If it was possible, we tried to use a 7 mm optical zone with a transition zone up to 8.5 millimeters. Let's turn to the results. All eyes had a low contrast visual acuity of 20/25, and this was the maximum that we have tested. The increase factor of the RMS wavefront error ranged from 0.6 to 2.3. So not all eyes were really corrected with the wavefront, only a few, about 20%, and a lot of them had also an increase in the RMS value. Compared to the data reported from standard LASIK treatments, which are in the order of 5, we have definitely reduced the increase factor of the optical aberrations. What we found is that the spherical aberrations were not significantly well corrected, so we are now trying to improve our ablation profiles. No eye fulfills the Maréchal criterion, which is known from technical optics, defined by RMS value should be smaller than a 14th of lambda. Let's go more to the clinical results. None of the eye lost more than 1 line of best corrected visual acuity. 20% of the eyes achieved supernormal vision of 20/10 or better. None of the eyes had an uncorrected visual acuity of less than 20/40. 28 of our 30 eyes were within ±1 diopter, and 26 out of 30 eyes were within ±0.5 diopters. I want to give you a short look about comparing the results between wavefront guided LASIK and standard LASIK. The standard LASIK has been done with the same laser, same microkeratome, the same surgeon. And what I want to give you is that there is an average and higher or better visual outcome compared to standard LASIK. The most interesting result, I believe, is comparing the increase factor of best corrected visual acuity with the increase factor of the higher order optical aberration. We found a very high significant correlation coefficient between these increase factors. What that means is that we are able to reduce optical aberrations. We will get a significant increase in the best corrected visual acuity. However, we don't know where are the limits of this technique. So in conclusion, mesoptic vision did not suffer from wavefront guided LASIK. Wavefront correction was far from complete. That means we do not achieve the standards for optical criteria. However, it correlated very well with the best corrected visual acuity, and that means that supernormal vision may be achieved by LASIK or by wavefront guided LASIK. Thank you very much.
Specific question on, you had mentioned that you undercorrected the spherical aberration. Just in nature of flattening the central cornea, you're going to increase the spherical aberration. Did you undercorrect the spherical aberration, or did you increase it as far as your polynomial expansion? Did you increase your 3rd and 4th order spherical aberration?
Oh yeah, no, not the 4th order. We increased the spherical aberration, which just corresponds to the sonic polynomial at cell 12. So the patient had a higher order, a higher spherical aberration after the treatment.
Right, and go on with that question. I mean, the only way to minimize that spherical aberration would be to make the cornea prolate. I mean,
yeah, sure.
And would you think that that's where you guys are heading as far as
we're working on doing nomograms that are correlated with the sonic polynomials, so that we make nomograms for each single coefficient.
Every operation was a primary operation, not a secondary operation.
Well, our patients were a primary operation. Thank you.